All right, good morning, everyone, and welcome back to our Metric Monday webinar series, where analysts and content experts explain the intricacies of measures and the data behind QCore reports. I'm Rebecca Bally, Facilitation and Improvement Specialist for Oregon Healthcare Quality Corporation. So before I turn things over to our expert, I just want to review a few things about the technology we're using today. Since we have so many of you on the line, everyone is and will remain on a mute throughout the presentation. However, we will be calling on you to share your thoughts and questions throughout the webinar and towards the end. So just a quick look here at your panel on the right side of your screen. We have time set aside to take your questions. So we welcome you to please submit questions at any time through this pane. And I will organize the questions for the end of the presentation. Please feel free also to send me, Rebecca Bally, or my colleague, Marissa Sweeney, a message via the questions pane if you're having any technical issues, and we'll do our best to assist you. Please note that we will send all webinar participants a link to the recording, slides, and additional materials after the webinar, and the recording will be available on our website. So very quickly again before we start, when you registered, everyone submitted a question, something they wanted to learn about developmental screening. And about a third of registrants wanted to know just generally about the measure, including the specifications, how it's measured. Some folks wanted to know about overlapping areas of care and different visit types. And then other folks wanted to learn about clinical improvement strategies. And I just want to give a heads up that we will not be covering clinical improvement strategies on this webinar. This webinar is for the metric and the measure data pieces specifically. However, if you are looking for some clinical improvement strategy resources, there are a few here that we've linked to in the slides that will be available when the slides get posted, and we'll also copy them into the chat pane. But QCore hosted a webinar on screening tools and referral training START, and the CDC has several guidelines, tools, and templates for developmental monitoring and screening. Also, the Oregon Pediatric Improvement Partnership, OPIP, has some resources on their website related to the CHIPR core measures, including a webinar about the billing code 96110. And of course, the Oregon Health Authority also has a guidance document on their website. So please take a look at these resources and keep your eyes out for future webinars from the Institute on this topic. So clearly it's a very important measure, and we'd like to provide assistance where we can. And now to our metric expert, Cindy McElhaney, who joined QCore in 2011 as a senior healthcare analyst. Her primary focus is on performance metrics, including providing consultation and validation for the Coordinated Care Organization CCO performance metrics developed by the Oregon Health Authority. And with more than 20 years of experience analyzing administrative claims data in her roles at a variety of health plans, Cindy works with fellow analysts to ensure QCore measures and reporting are both accurate and relevant to various stakeholder audiences. Cindy holds a bachelor's degree in mathematical sciences with a concentration in data science and statistics from Oregon State University. Outside of work, Cindy enjoys snowshoeing and walking, the latter so much that she participates in the Portland to Coast relay walk each year. So with that, I will turn it over to Cindy.
Hi, everybody. Before we get started on discussing the measure for today, I thought I'd just give you just a really quick overview of QCore. QCore is an independent nonprofit organization that is dedicated to improving the quality and affordability of healthcare in Oregon. We just celebrated our 15th anniversary this last November, so we've been around a little while. How we do this is through what we call a multi-stakeholder collaborative environment. We basically work with all sorts of different professionals that are involved in healthcare, from providers such as hospitals and clinics such as yourself and health plans. We talk to policymakers, we talk to employers to see what they want. We also try to bring in the consumer voice to see what patients need from the healthcare system and use all of that to inform our work. The next slide here, a lot of people aren't aware, if they're in the local market, that Q-Core is actually not unique. We are among a national network of collaboratives that are similar to us. There are 35 across the country that belong to an organization called the NRA, which stands for Network of Regional Health Improvement Collaboratives. And what's really great about belonging to an organization like NRA is Q-Core does not do its measurement work in a vacuum. We actually work with people across the country and get ideas and share best practices, and all of that informs our work. So here's the 4 things that Q-Core does to produce neutral information, which is one of our big key strategies for improving the quality of healthcare. We create and operate the most validated and utilized claims database in the state. Currently, we have 15 data suppliers. That includes the state Medicaid program. CMS gives us Medicare fee-for-service data, and then we have 13 commercial data suppliers that send their claims to us every month, or every quarter. And it represents about, I can never remember these numbers off the top of my head, we have about 82% of the fully insured commercial lives in the state of Oregon. We have about 90% of Medicare enrollees. That includes Medicare Advantage from the data suppliers and the Medicare fee-for-service. And of course, we have 100% of the Medicaid. So we have this huge database that really represents the people who live in Oregon. We report quality, utilization, and cost metrics to providers, health plans, and the public. We do pioneering analytics and reporting to help providers and healthcare systems improve cost of care. We have a whole other program that we run that's called Total Cost of Care, where we're trying to develop reports and metrics to help people keep down costs. And then we do custom reporting to stakeholders working on alternative payment models and quality improvement. And one thing that I want to mention is once a year we publish what we call our statewide report. It's kind of a high-level publication that's meant for policyholders that just kind of gives everybody a sense of how we're doing in the state. So now we'll launch in and we'll start talking about the developmental screening measure. So the measure itself is pretty straightforward. I'm going to talk about it upside down here on the slide. Your denominator for this measure, the population that's included, are children who turn 1, 2, or 3 years old in the measurement year and who meet continuous enrollment criteria for the 12 months prior to their birthday. So, for example, if we're looking at reporting the measurement year for calendar year 2015, all of these children that are included in the measure would then had their birthday where they turned 1, 2, or 3 during 2015. And the denominator is of those children, or the numerator, I mean, of those children in the denominator, how many of them were screened in the 12 months prior to their first, second, or third birthday for developmental screenings? Go ahead. What you should know, this is what we're going to try to go over during our slideshow today, kind of our agenda. We're going to go over the rationale for selecting the measure and the history of its development. We'll give you some details on how the measure is calculated. We'll show you some results that Q-Core has that show some real significant improvement in the state of Oregon. And then we'll give you a chance to talk. We want to talk a little bit about potential overlap of this measure with the well-child visit measure. Okay. So why is this measure important? It's an opportunity to engage families in the process of developmental promotion in addition to longitudinal and continuous developmental survey by knowledgeable healthcare professionals. This measure is actually a Children's Health Improvement Process, it's a CHIPPR measure, which stands for the Children's Health Improvement Process Reauthorization Act. Centers for Disease Control, it recommends that this measure be followed, and it's also a Bright Futures guideline measure. So selecting the measures, one thing that a lot of people don't know is that here locally we have the Oregon Pediatric Improvement Partnership, or OPIP, that is located up at Oregon Health Sciences University, and they actually have been selected by CMS to be the official measure steward for this measure. So what that means is that we're heavily involved in the development of the measure as far as the specifications, and they maintain the specifications as time goes on and coding rules change and all of that sort of thing. And they're essentially the measure owner and content expert. The Oregon Health Services Commission adopted Bright Futures as part of the preventive tables in the prioritized list of health services. The Oregon Health Authority had decided to adopt the schedule as far as how often the exams need to get done. And the OHA, as many of you know, adopted this measure as one of the CCO incentive measures when the CCO program first got up and running. At the same time, Q-Core made the decision that we wanted to align with the CCO measures in order to help clinics get patient-level detail and help them improve their rates. And so we also started reporting the measure at about the same time. This measure is also an early learning hub success measure. Oregon is working towards standardizing and well-coordinated screening practices across health and early learning, currently led by the Joint Early Learning Council, which is the ELC, and the Oregon Health Policy Board Subcommittee. They established a committee that's called the Child and Family Wellbeing Measures Work Group, which was appointed in 2015, and they came up with a list of measures that jointly between the Oregon Health Policy side and between the Early Learning Council would show what called kindergarten readiness and the type of things that children should have done to be ready for school. This is a measure that is on that list. Somebody in their questions in advance of the webinar had asked what the difference was between this measure and the one that they're using for kindergarten readiness. There is no difference. It is the same measure. So this is where we stand right now. This is from Q-Core's statewide report from last year. It represents data that's just a little bit old. I think this is through June of 2014. And our current rate is 29.9% of the children in the denominator are getting their necessary developmental screening. This is across the board for both commercial and Medicaid children are both included in this benchmark. One of the things I want to draw your attention to on this slide is on the far right, there is the Oregon's Best benchmark. What that represents is the performance of the top 10% clinics in terms of volume. The top 10% of clinics are achieving a rate of 76.1, which is what is achievable. So there are some clinics out there that are doing some really great work around this measure. Other thing we wanted to draw your attention to, this is also some data that was in the statewide report. There is some pretty significant geographic variation in this measure. We split this up. These are regions that Q-Core established for our reporting. And as you can see, there's a lot of difference by region on how well people do in this measure. Some of the best areas, Central Oregon is achieving a rate of 45.2%. Some of the worst performing areas on the North Coast is only at 20.1%. Eastern Oregon is 26.4. What this basically tells us is there are some great opportunities for improving this measure through collaboration and coordination. So calculating the measure, this is the one thing, we put a little graphic together. We'll see how well this goes to kind of explain how the measure works. As I stated before, the denominator for the population is basically children who have their birthday within the reporting period. But what is kind of confusing for people and takes a little bit of time to explain is that once you get that child's birthday, you're actually looking at a period for collecting data that is for the 12 months prior to each child's birthday, and it can vary per kid. So what we did is we put this chart together. See if I can get the mouse working right. There it is. right there. So the diamonds that are in white are intended to represent the reporting period here. In this example, we're using 2016. This is January 1st through December 31st of 2016. So for your denominator, you would pick any kid that turned age 1, 2, or 3 during that time. But then once you pick them, you look at the 12 months prior to their birthday to both check continuous enrollment and to see if they had a service done. So for example, child A, I may have to make Becca use this mouse because this is her computer. There it is. Child A turned 3 on April 4th, 2016. So the blue line here shows that their birthday goes from April, the 12-month period is from April 5th, 2015 through April 4th, 2016. The child needs to be continuously enrolled on their insurance plan during that period. There is an allowable 145-day gap in coverage, but in general they have to have coverage, and the service has to occur during that period. So going to child B, their second birthday, they turned 2 on January 16th, 2016, and so in their case, their continuous enrollment period starts January 17th, 2015 and runs through January 16th. Service has to occur in that period. So even though the reporting period is 2016, we are looking back into claims that go back into 2015 to calculate this measure. And then the last child, to kind of belabor the point, they turned 1 on October 30th, 2016, and their birthday, oh, we have a little boo-boo here that we just realized. That should actually go back to, no, that's right, it's October 31st, 2015. So those are the continuous enrollment periods. A couple of things that I wanted to bring up. This measure right now, as it stands for both Q-Core and for the OHA, is a completely claim-based measure. So the data has to be in the claim system for the screening to be counted. One of the questions we got ahead of time is that we know that some of these screenings are done in other settings, you know, in preschool settings, in schools, you know, out of the normal clinical setting. And what we can say is we know that we're missing that data. It's kind of an acknowledged thing, and that the hope is that it's consistent across regions and across all these clinics that were being measured, and that the data is still comparable, and that we can still track improvement even though we're missing this. One of the things that I know they're trying to do with the early learning hubs is to come up with methods for sharing this data with physicians. Part of it is to get rid of redundant services. You don't want your physician screening if the kid's already been screened, but you know, just opening up that information sharing. We're not quite there yet. The other thing, I'm still on this slide. I've got a few things to say about this slide. Sorry, Becca. We got another question, and it was a really good one. There's all sorts of screening tools that are you can use for the developmental screening measure, and the OHA has published a guidance document that basically lists which screening tools are allowed and which are not. Somebody sent in a question and basically said, how do you distinguish between the ASQ and the MChat screening tool? MChat is used for autism screening when they're billed with the same code. Just so you know, I don't have a good answer for that for you yet. I actually submitted a question to the OHA, and once we have the answer, we will share that out with you. We do know that the MChat is on the list of screenings that do not count for this measure because it's just an autism screen, it's not comprehensive, and so we'll get that figured out for you.
And also the Oregon Pediatric Improvement Partnership has a webinar on all about the code 96110, so we will be linking to that.
Right. Another question that we got in was, how does a patient missing a visit affect the overall measure? What affects the overall measure is not whether they missed a visit or not, but whether or not you were able to get that visit caught up and that screening done before the child's birthday. For example, if you have a kid that turned 2 during the reporting period and you didn't get the screening done until like a couple weeks after their 2nd birthday, it will not be counted for that reporting period, although the next year when they turn 3, it will fall into that 12 months and be counted. Okay. All right, and then here's some more data from our statewide report. This is comparing 2 reporting periods. One is July 2012 through June 2013, and the other is July 2013 through June 2014. Shows some marked improvement in the developmental screening rate. Statewide, all payer types, we went from 25.2% to 37.2%, which is just really a great result. And what's really interesting, there's a couple of interesting things. It is a CCO incentive metric, and so the CCOs were really working to improve this rate. We suspect that there may be what we're calling a halo effect on this, because if you look at the commercial rates, they improved markedly for this measure, and which is a really good result. And we think some of the procedures and processes that clinics are putting in place are kind of spilling over and bleeding over and improving things across the board, which is a great thing to see. One caveat that I would say on this improvement, a lot of the feedback that early on when this measure was first adopted that we got from clinics was that they had been doing these screenings all along. They just weren't coding for them on their claims. And so initially when you have that type of situation, you will see some of the improvement may not really be attributable to just changes at the clinic, other than they're doing better coding. But as time goes on, that kind of impact goes off. All right, so here is the last piece that we wanted to get your input on. Once a year, Q-Core goes through a process where we go through the list of measures that we report. We decide which ones we're going to retire. We decide which ones we want to add. The last time we did this, there was some discussion about the difference between the HEDIS well-child visit measures and the developmental screening measures. Q-Core has been reporting the HEDIS well-child visit measures for a number of years, just recently adopted the developmental screening measure with the OHA and the CCOs, and there is kind of an outstanding question on whether those measures are redundant. If we're reporting the same way, we had one person who basically said that the HEDIS measures were old and tired and they were tired of seeing them. And so basically, and then on the other side, we had people saying, well, they kind of get at different pieces of care. And so we kind of wanted to ask what your opinion was and to give us some input to kind of inform our decision making for next year.
Okay, so this is an opportunity for you to chat in, and I'll turn it back to the slide in a second. But again, you can enter in your thoughts into the question panel, and then we can make sure that we capture that. Also, though, if you would like to speak verbally, you can raise your hand. If you look at the attendees, and if you find your name, there's a little hand icon, and you can raise your hand, and we can unmute you if you'd like to speak your question. We'll just give a couple of minutes and let folks think about what they might want to say or share about this.
Right. So one thing to kind of spur your thinking, there were some discussion around the fact that the HEDIS well trial visit, a lot of those visits are kind of timed with the immunization schedule. And since Q-Core right now is not able to report childhood immunization measures, it's one of those things we're trying to get our hand on the correct data to do that properly. They thought it was a good proxy for seeing if immunizations were done. That would be something else we'd like some feedback on.
Okay, at this time we're also opening up to any other questions you might have about the measure. I know we tried to cover some of the questions that you submitted ahead of time, but if we did not, or if you had other questions that were sparked by the discussion, please feel free to enter those in now. The other thing is, if once you log off the webinar, you decide, oh wow, I really wish I would have asked that, or I really wanted to give my feedback on the reporting on well-child visits versus developmental screening, that would be a great time and a great thought to put in your post-webinar survey, which will pop up after you leave the webinar. Let me. Okay, we did get a comment. So we had a question about whether the social emotional screening is to be done at every visit or as indicated by provider, and that is more of a clinical improvement strategy question that might be answered in some of those resources that we alluded to earlier. Someone else chimed in and said, I feel that it is good to track the well visit, but there's redundancy in the process. Okay, thank you for that feedback. We have heard that from others as well. I don't think they're redundant. Not every practice has reached the standard of doing ASQs with every well-child visit.
Okay. Yeah, that's good feedback.
Good feedback as well. Is the link to the guidance document in the slides? Yes, you won't be able to click on the slides right now, but when we post the slides, the link will be active, and we will also include the links on our website to all those resources. It's clear that enrollment goes back 12 months for the denominator. Does the measure itself, the numerator, also look back 12 months, or does the screen have to be done in the calendar year 2016 this year?
Okay, and I apologize for not making that more clear. The screen also has to be done in that same 12 months prior to the child's birthday to be counted in the numerator.
So for example, when the child turns 2, between his 2nd and 3rd birthday, that was
exactly. Yeah.
Okay. Someone said they see the importance of both the well-child visit and the developmental screening measure, making sure that it's done for development, but with the well-child and the ASQ hitting both, shouldn't be done for the 1 to 3 years. Okay. Are the 2 types of screenings required by certain payer types? I'm not sure if you know that.
The way we run the measure and the way the measure is ran is we're following the OHA guidelines for the commercial population. So the same screenings that are recommended for in the guidance document provided by the OHA are also recommended for the commercial population for them to get credit for this.
Okay, did we have any other questions or anybody who raised their hand? Let's just check really quick. No? Okay. Well, thank you everyone for your great questions and great feedback. So I do want to say, if you have any additional questions, again, please feel free to enter that into the survey, the post-webinar survey, but also feel free to email Cindy with any of your specific questions. We have a couple more questions, but here's Cindy's email while we're sharing those. If I can pop them out here. So we had a question, what CPT code is used for the ASQ?
It is the same CPT code for a lot of the other screenings. It's 96110. That is the CPT code that is counted in the numerator for this measure.
And that is also the CPT code I referenced earlier that OPIP has a whole presentation on. So we didn't think that we could cover all the intricacies of that code in this webinar, but the Oregon Pediatric Improvement Partnership has done a great job with doing that. And that resource will be linked on our website. We had another question about what does the OHA state as the tool of choice?
There is a table that's in the guidance document that you're going to get a link to that actually has a list. I'm thinking off the top of my head. There's probably about 20 different tools listed there, and it indicates which are recommended and which are not recommended on that, or which are counted for compliance with the measure. So if you can refer to the guidance document, it's there. I know off the top of my head either the ASQ or the PEDS, the PEDS, which, forgive me, I don't know what the acronym stands for. Those are probably the two most commonly used tools.
Okay. And then the CDC also has several other recommendations. Someone else chimed in from Vancouver, BC. Thank you for calling in. With a CHC that needs to implement a robust quality reporting system for our primary care. Does your group work elsewhere? I.e., do we work in
Canada? You know, our mission is very Oregon-centric, but we also are collaborative, and we're always willing to talk to people. I guess that's the best way to put it. So if you would like to email me your information, and maybe we could have a short chat and see if there's anything we can do to help you.
All right. Great. And everyone, again, please feel free to keep send your questions afterwards if you think of them. I'm going to just show you here a couple of resources that we mentioned, but again, you'll get an email following the webinar probably tomorrow or so, and it'll have a link to our website with all of the resources that we've mentioned. And unfortunately, this will be our last Metric Monday for a while, but we do welcome your feedback and would love to continue providing whatever resources are available or are helpful for you. One last question before we sign off. When the MAs are entering the immunization into alert, the Oregon state system is not letting them enter the immunizations before their birthday. This contradicts getting them in their first, second, third birthday. Interesting.
That is interesting, but unfortunately we do not manage the alert system. And so that is feedback that needs to be pointed to the OHA.
Yes. Okay. All right, well, thank you, Cindy, and thank you all of our attendees for this morning. We appreciate you calling in for a little early morning, get your day started, and I hope you have a wonderful rest of the week. We'll see you next time.